Hi, I'm Josh McDonald.
And I'm Miranda Materi, and we are Hand Therapy Academy.
So, we're going to talk today a little bit about wrist salvage procedures. We don't necessarily see a ton of these, maybe do in your clinic, but there's a couple of different types, and they each have a different expected outcome for range of motion, strength, and kind of a different purpose given the patient needs and parameters. So, let's go through a couple of these and kind of just give you the data on, and so you can be familiar with the different options and what some of the outcome expectations are.
Yeah, and I think this is good to know to share with your patients and good to know as a clinician so you kind of know what the expectations are, but also know that there's a wide range and a lot of variety.
Yeah, yeah.
So, do
So
you want
let's
me to
go.
start? Yeah, I
Yeah,
can start.
go ahead and start. Let's cover proximal row carpectomy first.
Yeah, so proximal row carpectomy, that's the one, like if you ask me which procedure I wanted, that's the one I'm picking. And I'm happy to share the data. I think it was pretty um, favorable. And so the range of motion expectation is 60 to 65% of the contralateral side. So when in comparison, they're going to get about 60% back. Grip strength is 50 to 83% on one study. The other study was 91 to 100%, which I thought was interesting. So, two studies reported significant differences, but still, the one study was 91 to 100%. I mean, that's a lot of strength they're getting back. Um, I would say, from my clinical experience, it's usually around that 80% mark. And then key findings and clinical notes for proximal oral carpectomies, it's um, best at preserving motion and grip strength. They have stable outcomes, lower revision rates compared to a four-corner fusion. And this is for a moderate demand patient. So this isn't for somebody that's going to go back and start um, doing heavy lifting or heavy mechanical work.
Okay. And that's just where they're just removing that proximal carpal row. Everything becomes shorter. And so early on, the precaution is against any range of motion because we want those muscle tendon units to shorten now that they're on too much slack with that spacer gone. So,
Right.
yeah.
And not against any, it's okay to do some range of motion. You're just not doing that composite flexion
Yeah.
and composite extension stretching.
Yeah. Next one is four corner arthrodesis. This is another one of our more common ones that we'll see. And basically, it usually includes a scaphoidectomy where they're removing the scaphoid and then using plates and screws to lock down that side of the wrist. We usually see a percent of contralateral range of motion of the affected side at about 47 or 50% on one study. So that's decent range of motion. Not fantastic, not as good as the other one at the 60 to 65. Our grip strength, one study found 50% of the other side's grip strength, and one study found 60 to 74. So in both cases, our high and low end percentages are lower than the proximal row carpectomy. We have a little bit less motion than the PRC, more stiffness, and then higher complications with hardware and risk for non-union. Non-union because we want all of those carpal bones to fuse together. And so we're at a higher risk for them not fusing on this. Anytime you're putting in hardware, you've got more risk for time than when you don't put in hardware. So the PRC has a little bit less of those post-surgical complications.
Perfect.
Yeah.
All right, the next one we're talking about is the scaphocapitate fusion. So they're basically putting these bones all together. The expected percentage of range of motion is comparable to that of a proximal row carpectomy, so about 60 to 65% of the contralateral side. And then the grip strength is 70 to 90% of the contralateral side. So much more stable. And the patient, you can expect the patient to maintain a lot of their strength or a significant amount of their strength. So basically, similar range of motion and grip to PRC, but they do have a higher revision rate. And of course, the results depend on the surgical technique, which is for a lot of these. But this one is more dependent on the surgical technique. So for that one, you want an experienced surgeon.
Next one, a little less common one, radioscapholunate fusion. So we're just kind of locking in all the way down to the radius in that fusion. And so for range of motion, we're expecting about 30 to 45% because we have that um, radiocarpal joint fused more. So we're going to have way less mobility. Strength, you're still going to have around 50 to 70%. So that's decent. Still not for like a heavy duty kind of use application for a patient. It's the most motion restricted aside from a total wrist arthrodesis, the next one we're going to cover. And it's best for when we have an isolated radiocarpal pathology. So if you've got some arthrosis, or something going on between the distal head of the radius and the first carpal row, this is the one that's going to be the most effective there.
Awesome. The next one is the total wrist arthrodesis or total wrist fusion. So that one we know the wrist is not going to be moving at all. They typically fuse these in about 10 to 15 degrees extension. So you're in somewhat of a functional plane, and then it helps with maintaining digital flexion when you have a little bit of a wrist extension as well. The grip strength is anywhere from 80 to 90% of the contralateral side. So it's good for maintaining grip strength. Of course, the downside is that you don't have any wrist motion. This is great if you have a high demand patient or someone that has heavy work.
Okay. And then last one we'll cover is the total wrist arthroplasty. That's a mouthful at the end of the day.
It's hard.
Total wrist arthroplasty. And that's basically where your joint replacement. There's different options available, but they all have somewhat similar outcomes. You're going to have wrist range of motion about 50 to 60% of the contralateral side. That's usually enough to be functional. And you're going to have strength anywhere from 60 to 80%. In rehab of the hand, there's mentioned a study that has you at 72%, but that's still in that 60 to 80 range. And this maintains a fair amount of functional range of motion. It's one of the higher range of motion options available. But the implant lifespan can vary quite a bit depending on the patient's health and the surgeon's skill with it. And so this is usually best for older patients who aren't going to put as much load through it, just because that interface between the bone and the arthroplasty device can be questionable and can be a little unstable. It's just two different materials you're trying to join together. So best for older and lower demand patients who are not putting through a lot of load.
Yeah, so I think for all of these, I think it's interesting to look, because when you look at them side by side, because we made a chart basically comparing all the wrist salvage procedures, that their range of motion is all pretty much within that range of like 50 to 60% of the contralateral side. And then the strength is all around like 80% of the contralateral side. Of course, there's some outliers, but I think if you could kind of overall just picture that, and hopefully the chart helps as well. But just for our people who are listening and not seeing it, I think it's helpful to kind of group them all together, because they're all very similar, with proximal row carpectomies being a little bit better because there's less complications.
And so it kind of depends on what your patient or you are looking for. Do you want something super sturdy so you can get back to physical activity? Maybe a total wrist fusion is ideal. If you want something that just kind of like, hey, I'm still doing some stuff, but I'm not going to go crazy, then a PRC. If you've got an older patient and you want them to have good range of motion for mobility and peri-care and self-care stuff, and then maybe you're looking at a joint replacement. So there's options available there. But good to know the variation there.
Yeah. And I think the other thing to note too is if you do one wrist salvage procedure, you can still go on and have a total wrist fusion, right? Of course, that means another surgery. But if you do have one and it doesn't go well, or it's, I don't know, it just seems like giving those other options first for the right patient, of course.
Yeah. And there are surgeons who will specifically do them in a given sequence, because then you've got options left on the table. If you do a wrist fusion first, that's all you got. If you do the arthroplasty first, you can do a fusion after that, but you can't do a PRC. And so you start to limit your options when you do your multiple choice in a given order.
Right. Definitely.
All right. So if you are interested in seeing that chart, couple of things. We'll have it available on an Instagram post when we post this week's podcast. I'll try to make sure that is some of the video in our Instagram post. We'll also put it up in a post around about when we're doing this podcast, so you can find it on our Instagram profile. But all of this stuff is also available on our Hand Therapy Academy membership platforms. We have 3 different tiers. Top one is if you're studying for the exam, and the middle tier is kind of just your day-to-day continuing ed courses and all this kind of information. So reach out to us if you have any questions about that. info@handtherapyacademy.com, or you can find us on social media, Hand Therapy Academy.